So, we're revving up. Great. Part 2. Part 2. So what this is, this whole talk must be dedicated to my wife, Jen, who you can see there. I have the great fortune, hello, oh, I'm so sorry, I made a promise and I didn't keep it. Please don't forget to put your answers to the quiz thing. Where have they got to put them? There. Please don't forget to give this lovely lady who gave me a cup of coffee if I promised to say this. Right. Where was I? Oh, lovely wife. Yeah. I'm so lucky because I'm married to a consultant health psychologist. And she's devoted her life to the difference that hope makes to chronic disease. And really, when you think about caring for people with chronic disease, it's so often about helping people change behaviour, isn't it? We want people to exercise more, to not smoke, to eat well and live good lives. And it's weird really because we never ask the experts in behaviour change who are psychologists. So it's just lucky that I'm married to one. And there she is, Jen. And her book, she's written a book which there's a few copies left down there to give you more detail, right. So how is it that Norwood Avenue continues to improve our remission rate? So of the people who choose low carb, 52% of them will achieve remission. So if you're registered at my practice and you choose to go low carb, there's a 52% chance I'll have you in remission in 6 months. That's what we do. And why is the remission rate climbing? Why is it climbing year on year? And it's climbing because I'm endlessly fascinated by our failures. So I'm really interested in the people who don't manage to do this, and how can I do better for them, and how can I learn? And a lot of it is to do with psychology, as you're going to discover in the next hour, or however long we've got. This is just to prove to you that I am not prescribing drugs for my patients. This is nationally collected data on the prescribing in my practice, Norwood Avenue, compared to every other practice in the area. And you see we are the cheapest by far. We spend about half of what is average for the area, and we're saving £60,000 a year. The tragedy is we don't get to have any of that money at all. It just goes back to the Treasury. It doesn't finance. So really you have to almost be an idiot doctor because we're doing like extra work and it is completely unpaid. So it's hard for me to get some doctors enthusiastic about this approach, but you have to, I'd say, well, you do have to care for these people anyway, and it doesn't take a lot of extra time. But until we can, at the moment, the motivation for doctors is to prescribe more because it's so quick and easy. And we're not really rewarded, I don't think, for being patient-centred and not using drugs. But my practice, we're doing well with that. Oh look, here's Roy. Do you remember Roy, the guy that spoke to you? Well, this is old Roy, before he came, actually just before he came to see me. And that's his hemoglobin A1C graph. And you can see the first question mark is the very day that Roy came to see me for a 10-minute appointment. And the first question is, what did I do in that 10 minutes? Because if you look right from that day, his hemoglobin A1C dropped. So I did something. And what I did, I gave Roy hope. That's what I did. He was so upset to be told he had diabetes because he'd got friends with diabetes and his head was full of doom and gloom and amputations. And I said, you could have better health in a year if you're up for a proper behaviour change, if you do differently. And he said, okay, I'll do it. That's the first question. The second question, a separate question, how do we help Roy maintain his improvement? So many of you will have done well for a while and then you slip off the wagon and wonder why. Who hasn't experienced that? And so this session is about how do we give hope And how do we maintain a good habit? Oh, there he is again, Roy. And incidentally, Roy, having conquered one problem, has conquered lots of others. And he's an amazing artist and all things he wasn't doing before. His life has changed because he's now so lively. There we are, hope and physiology. That's what you've already done. So we're going to cover psychology. We're going to cover goals, resources, increments, and noticing. We're going to cover reframing failure, what to do with people who fail, and what does that mean? Food addiction. Does it exist? What is it? The idea of habits and willpower. How are we going to do with willpower? And also key is ongoing support. This is another one of my patients, and she's just showing you the skirt that she came to see me in at the very beginning. And she keeps that as a kind of, I'm never going to be that person again. And you can see her smiling there. Remember this, he is the best physician who is the most ingenious inspirer of hope. Samuel Taylor Coleridge, a poet in 1807. So these ideas are not new, the idea of hope. So Jen taught me that everybody has some hope somewhere. If you go to a doctor, presumably you're hoping to have better health. No matter how miserable you are, we all have some hope somewhere if you dig around. It's there. It's there. And if you can find out the hope within yourself or within patients if you're a clinician, you're halfway to helping them improve their lives. And the trick is how do we find out where the hope lies in. Sometimes people's lives seem really bleak and you can't believe there's any hope there at all. So how do we do this? The other thing I'd like to say is that I've been a GP trainer for something like 30 years. And so we video young doctors, and they're like I used to be. They're under time pressure, they're anxious, and they're in a hurry. They're in a hurry to sort of tell you to do stuff. They can't wait to tell you to prescribe stuff or you need to do this. And they don't realise, when I'm watching the videos, what I realise is the patients have shut off and they are not listening. And then the doctor afterwards is annoyed because the patient, but it's because you haven't motivated the patient in the beginning. So we shouldn't rush to tell them how to improve their lives, because the first question is, why should I? And you've got to deal with the why before you rush into the how. And I'm going to teach you now, in the next 5 minutes, just about all you need to know about behavioural psychology. So it's really well worth it. Just 5 minutes, and then we'll give you all diplomas because you're all going to be consultant psychologists. This work took my wife Jen 2 years. So she thought, right, what have I learned being a consultant psychologist, and can I simplify it to a point where we can teach it to anybody? And it took her 2 years to reduce everything she knew into this one slide. So the hint is GRIN, G-R-I-N, and that stands for things that we're going to learn. So let's start with G. G stands for goals. And this is what I'm talking about, is when I saw Roy for the first time, I don't want to hear about his problems, I want to know what he's hoping for. He was really hoping that he could minimise the effect of diabetes. He was hoping that he wouldn't need drugs. He was hoping, he wanted to be fit and active. Because do you remember him saying he walked with a stick? And that his mobility really worried him. So I turned his worries into goals, if you can see. So he was worried about mobility, so his goal is better mobility. He was worried about breathing better because he had a huge tummy, so his goal was to breathe better. He was wanting to lose weight. Now, weight loss isn't a goal, really. What you ask next is, what difference would weight loss make to you? So I never accept that somebody just wants to lose weight. I'm always fascinated to know, how could that improve your life? And then you get the real stuff, because they start telling me, well, if I could lose weight, I'd quite like to wear jeans. Or it's my daughter's wedding and I'd like to look smart. Or I think maybe then I could exercise more and I'd like to walk more. I get told all sorts of things. Once you know what your own goals are, or if you're a clinician, you know what your patient's goals are, you've got a shared purpose. And that's one of the things, all of us in this room have some shared purposes. Find your tribe with a shared purpose. It's powerful. It's also a lot more cheerful. Think about this. If you come to me with very severe depression, let's spend half an hour discussing how depressed you are. And do you want to kill yourself? And have you thought about how to kill yourself? And have you got a sharp knife? And all this kind of thing. It's really depressing. Or maybe we could talk about, if you weren't depressed, if I could help you with your depression, what would that enable you to do? And then you start telling me stuff about, well, I'd like to see more of my friends. So it's flipping a problem into a hope. And that's what I did for Roy, and that's what you saw Brian. He was full of fear about his mobility, but I flipped it into a hope. So that's G. There's the toolkit. So R. Again, as a young doctor, I thought that I was the expert and the patient was some kind of a blank piece of paper for me to express my genius. People come to us, they have resources, they have intelligence. Each of you has life experience. You have learned stuff and you know stuff. And if we don't find out what you know, we're not working together. Maybe you lost weight before. How did you do it? Under resources, who does the cooking? Who does the shopping? Is there anybody might like to help you with this? Sometimes you have a daughter or a next door neighbour. Each of us has resilience from life experience and resources. And tapping into the power of people's resilience and inquiring about resources is absolutely key to working together and getting to know somebody. And it doesn't take very long. It really doesn't. So that's R. So the next is going to be E. There it is. E stands for increments. For so many people, there's a big gap between their goal to write a book, climb a mountain, whatever, and how they are now. The E is about me saying to somebody, well, we both agreed you'd like to wear fashionable clothing and you're going to lose weight. What's the first step that is reasonable for you to take before you see me next time that we can agree on? And people tell me all sorts of things about their first step. I'll give up sugar in tea and coffee. I'll stop buying takeaways or what, I don't care, but it's their increment and it gives us something to talk about when the next come. And I get them to commit. Nobody leaves my room without, just tell me what you could do. What do you think might make a difference that we could talk about next time? So that's the increment. The final thing Jen thinks is probably the most powerful. And that is, so that's N, we've come to the end of GRIN. So that's N for noticing. So all day long, each of us is noticing stuff. We're getting information in our heads. We're hearing things and seeing things. A lot of it in medicine, we tend to notice negative stuff like depression or pain. But how about we could educate people to notice good stuff, like I think I've got more energy, or I don't need as much sleep, or my skin is better. That's noticing. So I'm always asking people about what you've noticed. And noticing improvements is also feedback. And we know that feedback is one of the most powerful things that governs behaviour change. So what I do with patients, I agree on how are we going to know that you're improving? What are you going to notice? So I get them to measure their waist, or weigh themselves, or look at clothing, or their belt, all sorts of things. And noticing improvement is very cheery, and then you tend to do more of it. So many doctors, I don't think they're curious, because patients go and they say, well, I've lost 2 stone, and then they never ask why. Or imagine, that's such a gift. We should be curious about success. We should be fascinated by what works, because then maybe we do more of it. So that's the GRIN model, G-R-I-N. Jen and I have written an open access paper on it, and if you Google GRIN and Unwin, there's a full proper paper on this subject. It also features in Jen's book that's at the back of the thing. I must tell you, she's written a book and it's not for profit. So we're not writing books to become rich. We're writing books to teach stuff. So all of the profit from the books goes to the Public Health Collaboration, a UK charity. So look, this is one of my patients. 2 forms of feedback. He's showing you with great pride his belt, because the hole he's got his thumb on is where his belt used to be. So he wears that belt as a constant, proud reminder of the weight he has lost. He's dead chuffed. You know, he says, I should throw this belt away, but I can't bear to, because it's my story. Because week on week, month on month, he's using different holes. And there is his weight loss. So he's lost 40 kilos. And he's as light now as he was in 1991. How about that? He's lost so much weight, it's really changed his life. So there's 2 forms of feedback there, 2 forms of noticing. There's him noticing his belt, which is what he prefers. His family like the graphs. So some of you will see me on Twitter, and I'm always publishing Graph of the Week, and I'm sure that guy's been Graph of the Week. It's so cheerful, and he doesn't want to spoil his graph now. And every time he sees me, he says, go on, do the graph, it'll be better. You'll all have heard of the placebo effect. So the placebo effect is, we know that if I give you a red tablet for pain, it's going to work better than a green tablet, even if it's just full of flour. Isn't that odd? And we're always trying to eliminate the placebo effect. When you do research, you're always trying to do a random control trial. You're trying to eliminate the placebo effect. The placebo effect can help with pain. It even helps with cancer, blood pressure, heart disease. So why are we always eliminating the placebo effect? Is the placebo effect hope? Hope that that tablet will help me. What's wrong with the placebo effect? Maybe it's part of the art of medicine. Funny, I got together with a shaman in South Africa, an old shaman, and when we got chatting, we used loads of similar things, and old doctors use all sorts of tricks, which is part of the placebo effect. About, I'll give you this strong cream. Shall I give you the strong cream or the weak cream? And they say, oh, I'll have the strong, Dr. Unwin. And that's always going to work better, isn't it? It's the placebo effect. But there's nothing wrong with the art of medicine in helping people feel better. And the placebo effect needs some thinking about. Oh, that was the paper that we wrote on the GRIN model, if anybody's interested and they want to read more about the GRIN model. But you can find it just by Googling GRIN and Unwin. Next one. Reframing failure. So my nurses used to say, well, Dr. Unwin, it's all very well and good this, but what am I supposed to do when I weigh somebody and they've gained loads of weight? Because I don't know what to say because it's so depressing. And in fact, so here we have a patient that's weight. So you'll see it number 1, number 2, and number 3. That's somebody who lost weight, but then look, they gained weight right afterwards. And number 1, number 2, and number 3. So what do you say to somebody who gains weight, that's cheerful and optimistic? So clinicians really struggle because you want to help your patients. So what I say is, well, yes, you've gained weight, and they say, oh God, that's terrible, I've let you down, I've let myself down. I say, this is all about, by the way, those increases in weight were nearly always Christmas for this person, and that's why the Christmas books are there, because Christmas, most people gain about a stone. So the question for that patient is, right, so this Christmas didn't go well, really. Do you regret this? And they say, yes. Well, it's not too late for next Christmas. What will you do different next time? What have you learned? Tell me. What could you do differently about Christmas or a holiday or our Sandra's birthday or whatever it is? What would you do differently? What have you learned? Because, you know, older people like me, we learn from experience and we do things differently. If you do the same thing, you will get the same result. So if you have the same Christmas, you will end up fatter every Christmas. I now have a very different Christmas. I've learnt stuff. And I help my patients do things differently. So what they need is hope. You did it before, you can do it again. Just do the same thing. But what you're going to do differently next time when you go to a birthday party. What you're going to do differently next time there's a celebration. Because people who go off the wagon, my wife Jen, if she goes off the wagon, it's 3 months till she's able to get a grip again. About 3 months. And by that time she's gained 2 stone. So going off the wagon for my wife is quite serious because it isn't one meal. She's off it for months till she gets a grip. So just to back me up, if you look at this patient, 1, 2 and 3, look how every single time they've lost weight, they've done it better than the previous time. He's learning. That patient is learning from experience and they do it better. Here's another patient. Slightly a very similar graph if you look. Again, somebody who is losing weight, well done, but then it all goes back on again. Yo-yo dieting. We all know about yo-yo dieting. It's a slightly different pattern. So what's going on? Why? This could be my wife. Why is an intelligent consultant psychologist doing yo-yo dieting? Why does she lose weight and put it all back on when she knows perfectly well that biscuits make her hungry? What's the answer to all the people that you all know that are yo-yo dieting? What is going on? Because it's odd, isn't it? Intelligent people are doing a thing that they know is wrong and will harm their health. What is it? Well, does it not remind you of another group of intelligent people who do something that they know is wrong but harms their health? What about people with an alcohol problem? They know that alcohol's not good for them. What about people with cigarettes? There are perfectly intelligent. My father was, he smoked 20 a day. I remember him burying his cigarettes one time, trying to stop it. He dug them up at 3 a.m. He couldn't get through without cigarettes. We're talking about addiction. And there's a big debate in medicine about whether food addiction is real. This is the graph of a food addict. They can't help it. And this is why we shouldn't be fat shaming. But this person is not doing this to irritate me. They're deeply ashamed. They've done it all their life. They hate themselves. They're fed up. But the model of food addiction is very useful because when you understand this as addiction, you can begin, at least if you know the problem, you can begin to think of a remedy. And this is the problem with moderation. My wife cannot moderate biscuits or cake. She really can't. I've seen it many times. She'd have one piece and then she'd be on secret eating and cooking and tray bakes and gaining so much weight. And that happened to her from the age of 16 to 50. And she's a psychologist. And then she's woken up and she's become absolutely fascinated by how to help people with food addiction. In medicine, the curious thing is, officially, according to the International Classification for Disease, food addiction does not exist. And that means there's no help for anybody with food addiction because it doesn't exist. So you can have gambling addiction where there isn't even a substance. So they can have help. And the people with cigarettes can have help. And the people with alcohol can have help. And the people with drug problems can have help. But food addicts, there is no help because it doesn't exist. And yet I know from clinical practice that this is what underlies many of the failures in the practice. These are people who try really hard and do very well. Then they go to a party, or somebody says, go on, it's just one piece of cake. And it isn't, actually. It's months and months. I absolutely know this is true. It took me a year to get off biscuits. 1 year. Am I a mad person? You see, I was kind of coping with clinics by eating biscuits, but I was having 6 at a time. 6 at a time, and I had them in my drawer, had them in the top right-hand drawer of my desk, and patients knew I liked biscuits, so they bought me loads, so the drawer was never empty. I couldn't get off them. I had to transition from biscuits to oat cakes to almonds, and it took me a year. Am I a mad person? I had a problem. And I think food addiction needs some thinking about, and most of you in this room know somebody who is a food addict. I'm convinced of it. This person, when they understood that it was food addiction, he realised that he'd been on Prozac for 11 years, and I had medicated him. So he'd said he was depressed, and he was depressed because he didn't like he had such a problem with obesity, he couldn't earn a living, and he couldn't lose weight because he was a food addict. But he just said to me, I feel sad the whole time, and I gave him Prozac for 11 years. That was not the problem. This guy now has 2 jobs. He works in a gym, and he has another job as well. So his problem about unemployment and finance was actually food addiction, only it took me 11 years, how slow is that, to get down to what the real problem was. And how wonderful for him to understand, and at least, he said, at least I'm not a mad person, because he thought it was too embarrassing to tell me about bread. With him, I think it was bread. And I've had people burst into tears and they say, you're the first person I have ever told that my weight is due to bread and it's a loaf a day. So for some people, moderation, I mean, there are plenty of the population who can manage moderation. Lots of them. And some of them are healthcare professionals. Well, bully for them. I'm really pleased for the people that can eat 1 chocolate or 1 biscuit. But it doesn't mean everybody can, and it doesn't help me to know that you can eat 1 biscuit. Not everybody. So this talk of moderation can be counterproductive for some people. Because then you're reassuring them it's okay. It may be okay, but I would say, have you managed just 1 biscuit in the past? And if I was to be honest, no, I never did. I could secret eat quite a few because I knew where they were. The children used to hide their Easter eggs, but I knew where they hid them. Or I'm the guy that when my wife put the chocolates on the Christmas tree, that night I would get up and eat the lot. I also knew where Jen kept the reserve chocolates for the Christmas tree, and I'd eat those as well. Because I'm like a mad person. An absolute mad person. The worst thing I ever did was I remember I was called out to a cardiac arrest. And that's kind of stressful. And it was 3 a.m, and my wife found me eating biscuits in the kitchen. She said, get out there now. They need a doctor. What are you eating biscuits? And it was, what is the answer to that? I'm a stupid addict. And I can't moderate chocolate biscuits. And some of you can't either. So we've done some research. Some of you will know that I designed or helped design the low carb program, which has been done by 460,000 people around the world. So we asked 1,000 of them. You can classify addiction by what's called the Yale Food Addiction Scale. And 1/4 of all of that 1,000 people were scored as food addictive. So 1/4 of these are just random people, 1,000 random people with diabetes. The good news is when they've gone low carb, their score dropped to normal in all but 8%. So you can do something about it. So these are a few things for any of you in the audience who don't want to buy Jen's book. This is what we do. People who are addicted to foods have trigger foods. I know mine is milk chocolate, it's trifle, it's Christmas cake, and the biscuits. Those are my trigger foods. I can't moderate them, but I know what they are, so I don't eat them. But I can eat other things, and it's not a problem. So be honest about what are your trigger foods. Be honest. And everybody with an addiction problem has to begin with honesty of where does the problem lie. And if you've never moderated something, you're not likely to suddenly start. And be honest about what it is. Also, my patients, remember I've learned from all my mistakes. My patients say, I say, go on, what's happened? And they said, oh, it's the biscuits. And I said, well, I thought you weren't having biscuits. And they said, well, I wasn't, but I bought them for the grandchildren. No, don't tell me it's for your grandchildren. We all know who's going to actually eat them. So I say, plan, all right, fair enough. What we're going to do now? Maybe you don't buy biscuits. Maybe you don't have them in the cupboards. Do something else with your grandchildren. Plan for success. If you've got a problem food, don't make it easily accessible. You know, if you're an alcoholic and your cupboards are full of whiskey, well, maybe you're going to drink it. If my cupboards are full of biscuits, I'm probably going to, particularly if I'm stressed, I could go there. An important thing, I think, is family members don't always understand this. So you're ashamed anyway, and then you don't want to tell your family members because you're not proud of this aspect. But it's much better actually to tell the family, I've got a problem, I'm going to try and eat healthily, please help me. So for a while I'm not having birthday cake and don't, please. Because otherwise we've all got feeders in the family they say, oh, go on, you're looking a bit thin. My mother rang me the other day, she's 86, and she said, David, I've been worrying about you, I think you're looking too thin. That's a mother for you. And I said, Mother, I've weighed exactly the same for the last 7 years. She said, are you sure? I said, yes, I have, Mother. I weigh myself. But she's a bit of a feeder. Mothers are feeders. So it helps to tell your relatives, I'm changing my diet. This is why I want to be healthy. Please help me. And then you're more likely to do well. The final question, I mean, there's lots more to this. It's a really complicated thing and a very difficult challenge. So Jen and I did it differently. Jen does cold turkey. She's amazing. She just, one day, that's it. She gave up alcohol like that. She just said, right, that's it, I'm not drinking again. And that was it, she hasn't. I'm a bit of a wimp, so it takes me ages. So I'm a transitioner. So I went from ginger biscuits to plain biscuits to the oat biscuits to the almonds. The danger of transitioning is if you get stressed during that time, if something bad happens, you go right off it. So that's the danger. But I'm just not a cold turkey person. So there's Jen's book. God love her. That's her lockdown baby. So she spent lockdown writing the book she wished she'd read when she was 16. She tried very hard to think what helps other people like her. And she's published it herself. And again, we don't make money out of it. Habits or willpower? What are you going to do? The point about this is, think about it. If you could get into a healthy habit, like say most of you probably brush your teeth, but you don't think about, I need to brush your teeth, nor do you stop brushing your teeth if you lose your job or you have an argument with your partner, because it's just a habit. Habits are more enduring than things you do with willpower. Willpower is somebody that's giving up carbs but then has some every Saturday or Sunday. So I think it's more useful, and there's evidence for this, to try and develop healthy habits in your life that are a habit. So I'm just in the habit of never eating bread. That's my habit. So I don't have to think, am I eating bread? I feel a bit stressed, so I'll have bread. I never eat bread. And that for me has been better, and it's worked. And it's all about each of us finding what works. If you can manage moderation, that's great. If you can have treat days, well, that's great. But if the evidence is you can't manage treat days, well, learn from that. Maybe you need to do habits, because they're very powerful and they're more enduring to periods of stress. Who is the person in a family that doesn't have a crisis? Which of us doesn't have deaths, arguments, problems? Particularly older people, you know, because the younger ones, they do stupid stuff and then you worry about them and you can't help them and then you get all stressed. So it's no good expecting a perfect life to come along and then you'll go sort your diet out. That perfect life never really exists. Let's deal with life as it is. It has ups and downs, and I find that habits are more enduring than willpower. Oh, here's a little thing. That's Chris. There's Chris. There he is. And that is Chris's hemoglobin A1C from 2009 onwards. And Chris did really well in the early days. And you'll see there his hemoglobin A1C, the sugariness of his diet, improved. Went down. Hooray. But oh dear. Look what's happened there. His sugariness has gone up again. Now, at that point, can you see by the question mark, there's a decision for the clinician. So, Dr. Unwin 10 years ago would have said to Chris, well, Chris, I'm a bit worried about you because your blood sugar's gone right up. I don't think that low carb is working for you. Sadly, I think we need to put you on medication. That seems reasonable, doesn't it? Because plainly, he's in danger because his blood sugar's rising. So something's going wrong, so let's use drugs. Is it likely that low carb GP is going to use drugs if he can do something else? No. This is what you really do. This is what you really do. Hello, Chris. Your blood's very sugary. Why is that? And Chris goes, oh, bloody hell, I know, it's the biscuits. And then I say, Chris, if we do another blood test in a couple of months, do you think your blood sugar might be a lot better? And Chris goes, yes, definitely, let's do that. Oh, look, and that's what happens. Because Chris is not a foolish person. He drifted. It wasn't that the diet wasn't working. He wasn't on the diet. He was eating biscuits. And again, I find clinicians start drugs when they haven't, they gave that chat at the beginning, but they forgot to revisit it because people go sugary by cycles. And it's so much more useful to ask Chris. So we call it carb creep, part of the addiction. We've all experienced that. Maybe Christmas happened. Maybe, I don't know, Chris is doing his best. But look at him now. He's another one of the 107 who looks amazing. And look how he's now learnt the lesson. He only had to learn it once. Years later, his remission is of better quality because Chris has learnt stuff, because Chris has resources. He's clever. He wants to be well. And I so nearly medicated him. And it wasn't necessary. I give people a chance. So yes, let's see what it is in a few months' time. Oh, well, that's that same person. It's just to prove that's remission that goes on for years and years, and it's somebody again who's had carb creep, and then they actually learnt it 3 times. That person had to do it 3 times. And that's another person, that's a lady actually, and that's another person I ring up every now and then and say, what's going on? Are we drifting? Yes, Dr. Unwin, I'll deal with it, don't you worry. She's a very formidable lady, that lady. She says, I'll deal with it. Leave it with me. That's all I need. That can take 30 seconds of a phone call. Doesn't need a 10-minute appointment. Oh, I love these people. That's part of one of the groups. So this is about maintaining long term, we can't afford to have one-to-one conversations with everybody, so we do it as groups. And those groups you can, you don't need an appointment, so people know that we have it on this whenever the date is. And those were groups, we did them for 11 years and years, and now they have to be Zoom. So we're doing it as Zoom, because the groups are fun really, because then you get patient experts. I often find that somebody will ask a question and then another patient will say, well, almonds are really cheap in Aldi, you know, or you need to do this, or they come up with recipes or all sorts of things. And it's a wonderful experience. I love group work. A few points about group work, and I was being asked by some of the clinicians about this. It always takes two people, I think, to run a group. You can't, you need somebody to check everybody in the room is okay. Somebody needs to feedback, so Jen's always there saying, I'm talking too much. Shut up, David, let them talk. You need that. The PHC is a charity, probably has somebody in your area that would supply somebody for free to help you run groups. Always try and get the expertise in the room to show itself. So try not to answer the question yourself. Say, has anybody in the room got an answer to that? It's really interesting. You never know whether to have an agreed curriculum or not if you run a group. If you have an agreed curriculum, that's a bit top down. It's quite useful at the beginning, but we haven't now, because we've got such a mix of expert people who've done it for years and the newbies. So we just kind of deal with whatever comes up. Yeah, poor control of blood sugar. Jen has taught me to see patients not as a problem. Wouldn't it be nice if we saw people not as problems? How sad if I go and see my doctor and he sees me as a problem. Here's David, oh God, he's going to moan, he's a problem. Jen has taught me to see people as a puzzle and to try and get the patient as well to see themselves as a puzzle, not as a problem. Because if you see it as a puzzle, you're beginning to want to prize it apart. It's much more hopeful, isn't it, thinking of yourself as an interesting puzzle rather than a problem. I have to say, on the whole, if you have a high blood sugar, really, let's be honest, it's nearly always something you've eaten. It is sometimes stress. As I say, my blood sugar now will be high, so it can be stress. But for 95% of the people I deal with, when they have a high blood sugar, they need to ask, what did I eat? So I think we've done it. You've got to the end, and you're all now experts in the David Unwin GRIN model. And you've done goals, resources, increments, noticing. You've done reframing failure, food addiction, habits and willpower, and some thoughts about ongoing support. And we'll just end with a nice quote. We should seek fervently to harness the power of hope in consultations by enhancing belief in an achievable, preferred future. Frank and Frank, 1993, they're Jen's heroes. That's where she gets all this from. There's some references. Well done, we got to the end. So there we are, we're all experts in psychology. It really, really counts. And if anybody wants to ask questions, I'll be very pleased to try and answer. Thank you very much. Thank you.